Good evening, everyone. Welcome for this lecture from DOM Academics. Today, we are having a neurology lecture, fourth lecture in the series. Dr. Rohit has come. Thank you so much, sir, for coming. He is alumni from here, UG, PG, and he has completed his DM Neurology and presently working in the Department of Neurology. Thank you so much, sir, for coming. Over to you, sir, for the lecture.
Thank you, Jennifer. Thanks for inviting me to take this lecture. I'm sharing my screen. Okay, is it in slideshow mode? Can you see?
Yes, sir.
Okay, good evening, everyone. So today's talk is about approach to inflammatory disorders of the central nervous system. So as you can imagine, this is an ocean. And so we will be focusing on only some few areas so that we can take home some few relevant points. So this is what my outline is going to be. I'm going to talk about the spectrum of inflammation and what is implied by inflammatory brain disorders as opposed to brain disorders with inflammation. And then try to understand some basic outlines for principles to approach these inflammatory CNS disorders, and maybe go through the criteria for multiple sclerosis and neuromyelitis optica spectrum disorders with some detail, and then just brush through some other test case scenarios and spotters to just give us an exposure to some of the important disorders in this group. All right, so let's get going. So inflammation, as we remember from our pathology days, refers to redness or pain or swelling or warmth in an area. And this is what we traditionally remember. But in the brain, it's actually a more complex entity. For one, because we can't see the brain, of course, and we can't identify these traditional signs. And secondly, because brain tissue is peculiar. The intrinsic tissues of the brain, which is the neurons and glia, are themselves capable of mounting an inflammatory response, as opposed to other tissues where the inflammatory response is mainly mounted by extrinsic components like T cells, B cells, antigen presenting cells, and other immune cells. So that's very important to understand. So as you can imagine, this gives a potential scenario where inflammation can occur in a wide variety of disorders. Anything that can possibly injure or irritate the brain can result in an inflammatory response. The microglia are one of the chief mediators of these responses. These are resident macrophages which remain in the CNS. They enter the CNS in early embryonic life at around 9 to 10 days and persist there. In the resting state, microglia have a dendritic appearance, like a tree-like arborized look, as you can see here. But when an inflammatory process is occurring, the microglia become more amoeboid. Their processes become thicker and contracted. And this is one of the easy clues to identify an inflammatory response in brain parenchyma. So this picture that you can see here actually is a slide taken after traumatic brain injury. And as compared to normal brain, you can see that there is evidence of inflammation, even in traumatic brain injury. So neuroinflammation then is the response of reactive elements of the nervous system to altered homeostasis, whether it is internal or external in origin. So anything that disturbs the brain can result in an inflammatory response. That's important to understand in the context of discussing inflammatory brain disorders. So broadly, we can classify these disorders into inflammatory brain disorders, like the traditional syndromes that we associate with this term, including multiple sclerosis, neuromyelitis optica, SLE, sarcoidosis, Sjogren's, etc. And then there are a whole group of disorders which have inflammation but are not primarily inflammatory in nature. So these are the brain disorders with inflammation. And this includes brain trauma, stroke, even Alzheimer's, migraine, the pathophysiology, which involves things like substance P, which are inflammatory mediators, epilepsies, neuropsychiatric syndromes, and so on. So there is data that shows that even Alzheimer's responds to non-steroidal anti-inflammatory drugs, and epilepsies respond to treatments like steroids. So sometimes you may wonder why neurologists have a low threshold and a penchant for using immunosuppressions. So it's this broad understanding that inflammation is a part of many other disorders, which gives us this leaning towards using anti-inflammatory drugs quite often. So this is very important to understand when we're talking about inflammation and the brain. But today, for the sake of limited time, we will deal mainly with inflammatory disorders and not the secondary inflammatory disorders on the right side of the screen here. All right, so as I was thinking about how to put this across clearly, I came up with this mnemonic, and it's not from literature. It's something that I made up myself. And I hope it will enable us to take back some principles on how to deal with these disorders. So I call it the SCOPE approach. So SCOPE referring to something that we use to find a target. Okay, so what do I mean by SCOPE? First, is there a clue to a particular syndrome? Is there a typical syndrome in the disorder we are facing? Second, is there objective proof of pathology? So this objective proof is something that goes beyond the patient's subjective feeling or interpretation or report. So it could be a clinical sign, it could be radiological evidence or electrophysiological evidence or serology. So we need objective proof. We need exclusion of mimics finally. So if we can meet these three requirements, a clue to a particular syndrome, objective proof of pathology, and exclusion of relevant mimics, we should be able to arrive at a reasonable diagnosis. So let's apply this in different scenarios. So the CNS syndromes involve the brain and spinal cord. And for convenience, we can divide these into white matter syndromes, gray matter syndromes, and syndromes that involve the other structures, which are the vessels and the meninges. So this is useful because it not only gives us a clue to pathology, but also clinical symptomatology. White matter syndromes involve typically optic nerves, spinal cord, the brain stem, and the cerebellum or its connections. Gray matter syndromes typically involve the cortex, basal ganglia, which is the caudate and putamen, or the globus pallidus interna and externa, or the thalamus and its brainstem nuclei. And the other syndromes typically involve arteries, which includes a large, medium, and small vasculitis, venous sinuses, and meningeal disorders. So the corresponding symptoms that would be associated with these syndromes, white matter syndromes would typically present with features like vision loss, anterior vision loss, so uniocular vision loss with a relative afferent pupillary defect. Spinal cord disorders would present with motor or sensory, partial, or complete transverse myelitis syndromes. Brainstem syndromes would include internuclear ophthalmoplegia or palatal myoclonus in cases of involvement of the dentatorubro-thalamic tract, or the various brainstem syndromes involving sensory or motor pathways, and of course, cerebellar involvement. So if you see a typical symptom and you can think of a white matter localization, you're probably dealing with a white matter syndrome. Gray matter syndromes, on the other hand, mainly involve the cortex. So if you have cortical involvement, the symptoms will often be seizures or cortical deficits like cortical sensory loss or aphasia or hemianopias of cortical origin. And in case of basal ganglia involvement, we would expect to see chorea or bellismus or other movement disorders or impaired consciousness. And vascular syndromes and meningeal syndromes, these two structures alone in the cranium are pain sensitive. So pain will be a prominent feature, and focal deficits will be in a vascular distribution, and sometimes raised intracranial pressure may be a symptom because of the meningeal involvement. Okay, so let's keep this approach and keep working on it further. So tissue, site, and symptom. So let's apply those principles that we discussed about. A syndrome clue. So in an optic neuritis, the possible diagnosis would, of course, be multiple sclerosis or neuromyelitis optica spectrum disorders, sarcoidosis or vasculitis. So in multiple sclerosis, the symptoms are usually not as severe as NMO, for example, although that's not a hard and fixed rule. Some other clues like the Utah's phenomenon, which is worsening after exercise or a hot bath, may suggest multiple sclerosis. NMO usually has severe vision loss or bilateral vision loss. Sarcoidosis very often has multiple cranial nerves involvement and may also have uveitis. And vasculitis will typically present with an altitudinal field effect, like the curtain, I forget the word, but the phenomenon, amaurosis fugax, right? So these can give us a clue to the etiology. Spinal cord syndromes, of course, multiple sclerosis is a possibility, but in MS, the syndromes are usually asymmetric, unilateral, and peripherally located in the cord, like a hemisensory syndrome, while NMO causes severe central cord involvement. So usually it's a complete transverse myelitis, sometimes with features of necrosis and flaccidity. And sarcoidosis produces a variety of syndromes. Brainstem involvement is particularly characteristic for Behçet syndrome. So that's one thing to keep in mind, although it's not as common as multiple sclerosis. Anybody presenting with the brainstem syndrome, always consider Behçet, especially a male. And of course, vasculitis and cerebellar involvement can occur in all of these as well. So once we have a suspected etiology, we have to now establish objective proof. So how do we do that? So clinically an RAPD is sufficient proof, or if there is optic disc pallor, or a visual evoked potential showing an asymmetric or unilateral absent response. MRI will require special additional sequences like a fat suppressed gadolinium sequence to see the optic nerves well, or an ocular coherence tomography. These can be used for optic nerves. For the spinal cord, in addition to clinical and MRI, the evoked potential studies are very useful and very sensitive for sensory dysfunctions. And transcranial magnetic stimulation can actually be used for motor as well in this context. Brainstem involvement, apart from clinical and MRI, brainstem audiometry evoked response can actually give us a fairly accurate idea of the level of involvement in the brainstem. And the cerebellum will depend on clinical and MRI assessment. So once we have a syndrome clue, we have to establish objective proof of the localization, pathology, and of course, exclude mimics. So there are a lot of disorders which can mimic these. Non-arthritic ischemic optic neuropathy is one important non-inflammatory syndrome. Of course, arthritic is an inflammatory syndrome. Toxic disorders like methanol poisoning, various drugs, and ethambutol and so on. And Leber's hereditary optic neuropathy, which is a mitochondrial degenerative syndrome. And nutritional disorders like B12 and copper deficiency, all of these can also mimic optic neuritis. So these need to be carefully excluded. Spinal cord syndromes, of course, ischemic and atherosclerotic diseases, especially aortic aneurysms. nutritional, as we mentioned, copper and B12, and the entire spectrum of hereditary spastic paraparesis and so on should be carefully excluded. Brainstem disorders, apart from the atherosclerotic, the other important mimics here are osmotic dysmyelinations and Wernicke's aphasia, and of course, the infections, progressive multifocal leukoencephalopathy, which is HIV related. And cerebellum is particularly vulnerable to various toxins, including the organic solvents and mercury and heavy metals and so on. So these are important differentials to be excluded when making a diagnosis of an inflammatory disorder. So a syndrome clue, objective proof, and exclusion of relevant differential diagnosis. So having dealt with white matter, let's take a quick look at gray matter syndromes. So gray matter syndromes typically, for example, would be limbic encephalitis and Hashimoto's encephalitis, which is also called steroid responsive encephalopathy with antibodies to thyroid. Okay. Chorias of inflammatory origin can happen in a variety of autoimmune syndromes. Some typical examples are lupus or antiphospholipid antibody syndrome itself, rheumatic chorea, the Sydenham's chorea, and post-streptococcal chorea, especially in children, what was previously known as PANDAS, pediatric autoimmune neurological disorders. And thalamic and brainstem involvement happens, for example, in acute necrotizing encephalopathy, which was something we saw fairly regularly in the coronavirus and the previous H1N1 epidemic waves. So it's a post-inflammatory disorder with typical appearances. And Bickerstaff brainstem encephalitis is actually related to Guillain-Barré syndrome in pathophysiology, but also involves brainstem function. So how do we establish objective proof? For each of these, there are antibodies. Limbic encephalitis has its own paraneoplastic and other antibodies like LGI1 and Casper. Hashimoto's encephalitis is diagnosed with the same antibodies that are involved in autoimmune thyroiditis, thyroid peroxidase and thyroglobulin antibodies. Of course, MRI and EEG evidence of pathology is required. And similarly, also specific antibodies for the related syndromes for basal ganglia involvement. And Bickerstaff encephalitis, ganglioside antibodies may be useful. Okay, so we talked now about gray matter, and last, okay, let's exclude mimics. So some mimics of inflammatory encephalitis, of course, viral encephalitis, which is obvious. And metabolic disorders like mitochondrial encephalopathy with lactic acidosis and stroke-like syndromes. Sturge-Weber syndrome, which is angiomatosis, can very often be deceptive unless the stain is obvious, because it produces a focal appearance like an enhancement over the cortex. We've had cases where we were not sure if that was focal encephalitis, but later on it turned out to be a Sturge-Weber. Focal cortical dysplasias, which are congenital in origin, may manifest later in life as a small focal hyperintensity and causing seizures. So these are all difficult differentials, which we see regularly. Among the chorias in movement disorders, hyperglycemic chorea, especially hemichorias, is something we see frequently. And mitochondrial disorders can present with chorias. Hypoxic injuries, carbon monoxide poisoning, all of these can also present with basal ganglia involvement, because the basal ganglia tissue is very energy dependent. So any interruption to energy flow will actually affect these structures. And of course, again, thalamus and brainstem, the same differentials. One important differential here is Listeria rhombencephalitis, which produces brainstem involvement. So these are the things to be excluded for suspected inflammatory gray matter syndromes. So the vasculitis syndromes, large artery involvement, Takayasu is typically presenting with large artery strokes, giant cell arteritis in middle-aged populations, unilateral blindness, headache, Kawasaki's, and the related syndromes that we've been seeing in pediatric population as well, MSC and so on. For medium artery involvement, the primary CNS angiitis, systemic vasculitis, and Suzak syndrome, these are differentials. And Behçet's disease, apart from causing brainstem involvement, causes prominent thrombosis, especially cerebral venous thrombosis. So these are some of the important syndrome clues here. Mimics to be excluded. Varicella produces a large artery angiitis and should be carefully looked for. The PCR is not reliable, but rising antibody titers is a good way to make a diagnosis here. And fibromuscular dysplasia is a non-inflammatory condition, a collagen disorder, which may mimic a vasculitis, but usually doesn't involve the intracranial arteries. Again, varicella can also produce a small vessel vasculitis, hepatitis B related cryoglobulinemia. Fabry's disease is one important differential for anyone, especially a young adult presenting with stroke-like syndromes. And CADASIL, which also presents with headache and white matter changes. Okay, so having broadly covered various disorders under the headings of white matter, gray matter, and vascular and meningeal, let's move on to some of the important common disorders and try to familiarize with them. Okay, so you can put your answers in the chat. What is your diagnosis here? So this is a 17-year-old female with acute vision loss in the right eye since 1 week. Her visual acuity was 6/36 in the right eye with a relative afferent pupillary defect. She had no prior symptoms. MRI, unfortunately, here is negative, which can often happen in practice. But her VEP shows an abnormal right side P100 latency, but normal on the left. Her CSF shows a mild protein elevation, and her oligoclonal bands are positive. So would you diagnose multiple sclerosis here? Or would you diagnose something else? So how do we diagnose multiple sclerosis? Okay, so MOG antibody was one of the suggestions. That's a good thought. We'll look into that as well. So MS is diagnosed on the basis of these principles, very similar to what I mentioned earlier. A typical syndrome is first required, and objective evidence of pathology, okay, is also required, as we said earlier. So what are the typical MS syndromes? Optic neuritis, brainstem syndromes like INO, trigeminal neuralgia, the cerebellar and spinal cord syndromes, the white matter disease spectrum, basically. Objective evidence, as I said earlier, just going by history can be erroneous. Yeah, thank you for your answers. We'll keep moving along. And so MRI or VEP evidence is required. But more than that, MS is a disease which has to establish multifocality and chronicity. So dissemination in space and time has to be proved. And of course, exclusion of other alternatives. There should be no better explanation than multiple sclerosis. So let's look at that carefully. So what exactly do we mean by dissemination in space? So this is defined as detecting lesions in more than one objective site in the central nervous system. So that's very easy when a patient has had 2 attacks at 2 different sites. For example, an optic neuritis and maybe several months later, spinal cord syndrome. So that gives you your dissemination in space. But sometimes the patient has just come to you with 1 attack. So can you still prove dissemination in space? Yes, you can with the MRI. So what is the MRI evidence we look for? So researchers have classified the zones of the MRI into 4 sites: periventricular, cortical, or juxtacortical. So previously these were 2 separate sites, but now they've been clubbed: infratentorial brain or spinal cord. So why this is important is most other differentials like unidentified bright spots in migraine, for example, or small vessel ischemia are not commonly going to involve all these sites simultaneously. So if you can establish that 2 or more of these 4 sites are affected, you can prove dissemination in space. One important point is that the optic nerve MRI is not included amongst these 4 sites, perhaps because it's not reliable. Okay, so the typical lesions in multiple sclerosis are like this. So you can see that they arise from the callososeptal interface, the margin between the corpus callosum and the septum pellucidum, which is beneath it. And they radiate outward in spokes. And that is the pattern of the veins actually. So there is a perivenous outward spokes called Dawson's fingers. You may have heard this term. So if you see this classical pattern, callososeptal, radiating Dawson's fingers with some areas of cavitation or black holes on T1 images, you're very likely to be dealing with MS. So this patient has got periventricular involvement and some deep white matter involvement as well, and some juxtacortical involvement. So he or she would have 2 of the sites required to make a diagnosis. So this points out the juxtacortical or cortical lesions. Okay, as here as well. Okay, so apart from dissemination in space, the second criteria required to be proved is dissemination in time. And this is defined as detecting new lesions over time to suggest a chronic ongoing disease process. Why this is important is because many diseases like ADEM or some of the even MOG syndromes may be monophasic and not progressive. So it's important to prove that the patient has an ongoing disease process. So some of the recent ways to prove this in the 2017 criteria, recent I'm saying compared to the earlier criteria, of course. One is, of course, if the patient has 2 clinical attacks, the diagnostician's life is very easy. But if the patient has a single attack only, is it still possible to prove dissemination in time? Yes, it is, because the MRI can actually show evidence of both current and past disease. Okay. Is there some noise? Can we mute that? Are we okay? All right. So the MRI can actually prove both acute and chronic disease, and we'll look at that shortly. The other way to prove dissemination in time is to show positive CSF oligoclonal bands, because these are very likely very low positivity in close mimics of MS like Neuromyelitis optica, only 20% positive. But in MS, they're more than 80% positive, and they do suggest chronic ongoing inflammation. So these are ways to prove dissemination in time. Now, coming back to the MRI, there are 2 ways you can prove that there is dissemination time. One is to do a second scan or to look back at the patient's old scans. And if you can show that a new lesion has appeared more than 1 month apart, that confirms the dissemination in time criteria. The other way to do it with just a single scan is to actually see both acute and chronic lesions together. So how do you know it's an acute lesion? It's gadolinium enhancing. It may be also diffusion restricting, but that's not included in the criteria. So a gadolinium enhancing lesion plus a non-enhancing lesion on the same scan immediately proves dissemination in time. Okay. So this is the summary of all that we just talked about, the 2017 McDonald's criteria. So if we have 2 clinical attacks with objective evidence, so suppose the patient comes to you with saying he's got vision loss, you need to have either papillitis or an RAPD or an abnormal VEP. And if you can show that there have been 2 attacks in 2 sites, for example, alternate eyes, that itself is sufficient for the diagnosis. However, if you have only 1 attack, but definite documented records saying that the patient had another attack a few years ago in another site, that is also sufficient proof. But if both the attacks have occurred on one site, for example, 2 attacks of right eye optic neuritis, then your dissemination in space criteria will not be fulfilled. And so you need to wait for additional evidence. So this is a scenario like the case we discussed, where you would repeat a scan after a month. On the other hand, if the patient has had only one attack, you do a scan and you see two lesions. So you saw the right eye optic nerve changes, and you also saw periventricular changes, which are showing gadolinium enhancement. Then you can actually confirm dissemination in time as well. So even with one attack, what is known as a clinically isolated syndrome, if you're able to use your MRI to prove dissemination in time, or if your OCBs are positive, you can prove dissemination in time and you can make a diagnosis of MS. So this is very, very important in the West because, as you can imagine, the payment is not by the patient themselves, it's usually by insurance. And insurance will not support unless the diagnosis is substantiated. So that's why these criteria have been refined and made very specific. So let's go back to the test case A. 17-year-old female with acute right eye vision loss, visual acuity of 6/36 with the RAPD, no prior symptoms, no MRI lesions, VEP abnormal on the right, CSF OCB positive, and increased protein. Okay, so put your answers in the chat, please. So can we diagnose multiple sclerosis in this patient with this evidence? Yes or no? Okay, so thanks for answering. Let's look at that again closely. So is it a typical syndrome? Yes, optic neuritis is a typical syndrome. But you're right, there is objective evidence of clinically isolated syndrome, right eye optic neuritis, but there is no dissemination in space because you've only got objective evidence of optic neuritis. We don't have any other site, but you can prove dissemination in time because the OCBs are positive, even though the patient has had just one attack. So what will you do next? So what you will do now is you will wait for additional evidence, repeat a scan after 1 month. Okay, and now if you find a new enhancing lesion in another site, for example, the periventricular, your dissemination in space requirement is satisfied and you can now diagnose multiple sclerosis. So this patient would then be diagnosed as clinically isolated syndrome because he's only had one clinical attack, but MRI basis wise, it's active disease. So we use the defining term clinically isolated syndrome, active disease. Yeah, thanks for answering. And Sakshi, you got it right. Good job. Okay, let's go to the second case scenario. A 34-year-old female with a right acute hemisensory syndrome. Okay. And 2 years ago, the patient had transient right eye blurring for 1 week. So what do you need now? So you've got typical syndromes. Now, is there objective evidence? So here the visual acuity was normal bilaterally and RAPD was negative. But the MRI showed a right spinal cord plaque, which was gadolinium enhancing, but the brain MRI was normal. However, a visual evoked potential was done, which was abnormal in the right eye, corroborating the historical account of transient right eye blurring. Oligoclonal bands, unfortunately, were negative, and other markers were negative. Can we diagnose MS in this patient? What do you think? Okay, so Sivaranjani, I think, has said yes. Okay, Narmadam has said yes. You are right. So we have a typical syndrome. We have objective evidence of two sites, both the partial myelitis and the previous right eye optic neuritis. We are able to fulfill dissemination in space, cord and optic nerve, and dissemination in time because of the more than 1 month gap and objective attacks. So the patient can be diagnosed with multiple sclerosis. Okay, the third case, a 34-year-old female with right eye acute hemisensory symptoms, and 2 years ago had similar history, and MRI again showing right spinal plaque, but VEP was normal. So just a slight modification of the previous scenario. So again, we are back in the previous situation where we don't have objective evidence. Okay, so this is a patient with a spinal cord involvement and acute partial transverse myelitis, but evidence lacking for right eye optic neuritis because the VEP was normal. So the patient again does not have dissemination in space, but has dissemination time. What you will do next is wait, repeat scan after 1 month. Okay, so some important terms to understand in the MS phenomenology, what is meant by relapse and remission, pseudo-relapse, progression, pseudo-progression, and activity. So previously in 96, the terminologies for MS were relapsing remitting MS, primary progressive MS, secondary progressive MS, and progressive relapsing MS. But in 2013, this was modified with the introduction of the term I used already called clinically isolated syndrome. And primary progressive and secondary progressive were together classified as progressive disease, while RRMS was retained. And the term progressive relapsing was abandoned. Okay, so clinically isolated syndrome needs to be further classified based on the MRI as active or not active. And if it's not active, it's called a solitary sclerosis. And similarly, all the other terminologies also need to be classified as whether they are active or not. Now, one important point is that activity and progression are different terminologies. I'll show you that in a second. Okay, what is meant by relapse? Relapse is either symptomatic or asymptomatic. Symptomatic relapses is a new distinct focal CNS syndrome. Very rarely it can be multifocal. It follows a typical pattern of a demyelination, occurs over days, plateaus, and recovers gradually over a few months, about 3 months or so. But even without symptoms, a relapse can be diagnosed by MRI alone. So a new MRI lesion without symptoms is an asymptomatic relapse. Okay, so this is the terminology relapse, and remission is a period of improvement of remyelination. What is a pseudo-relapse? A pseudo-relapse is when a patient has worsening deficit, but actually without activity. So there are many reasons this can happen, like we talked about the UTOF phenomenon. Due to exercise or fatigue or infection, the conduction across the damaged axons, unmyelinated axons, may actually get blocked. So this doesn't mean that the disease is reactivated. It just means that there are yet to be myelinated axons in that CNS. So that's one important differential, because you should not treat these with steroids and immunomodulation. These are actually pseudo-relapses. So usually they improve in 24 hours. But if they don't improve, imaging is required. So active disease, as I just mentioned, depends on new relapses of clinical or MRI activity, or change in the appearance, increasing size or enlarging lesions. Now, if there's no change in activity for 1 year, this is termed as NADA, or no evidence of disease activity. So these are all terminologies used in MS. Now, as I said already, activity and progression are different things in multiple sclerosis. And that's one of the reasons why the 2013 revision came about, because it was later found that even without activity, patients can develop progressive disability. So progression actually refers to insidious and irreversible worsening of function over years due to progressive axon loss. So nobody really understands why this happens, but generally around the 4th or 5th decade, I would say actually 5th decade, patients who have been having MS go into the progressive or degenerative phase. And this leads to increasing disability, and unfortunately, it doesn't respond well to immunosuppression. Pseudo-progression refers to the other problems that come along with aging and secondary comorbidities like immobility, deconditioning, joint disease, Parkinsonism. All of these can also lead to worsening disability, but it's not due to neurological or MS worsening per se. Okay, so this important graph actually illustrates this. So the graph that I'm pointing to now on the left side shows patients who develop symptoms very early in life. Some of them develop symptoms in the first decade or second decade. And these patients were either secondary progressive or single attack progressive or primary progressive. So primary progressives usually start a little later. But irrespective of which type of MS they were, if we look at the progressive phase, they all enter the progressive phase roughly around the age of 40 or so. So what does this prove? that all forms of MS eventually enter the progressive phase simultaneously around the 5th decade. And this progressive phase is age dependent, which means around the age of the patient, but it's agnostic to how long they've had symptoms. So even if you had RRMS from the age of 16, the progressive phase invariably begins around the age of 40 or 45 or so. And that's an important point to note because treatment will change. Okay, so having dealt with MS, let's move on. What does this patient have? Okay, this is actually a case that we had, which we had reported. A 30-year-old female who presented with recurrent vomiting for 3 days, followed by a sensory level, the cervical with sensory, followed by quadriplegia and urinary. Patient had a flaccid myelopathy. So this was neuromyelitis optica. This was a revolution in diagnostics in the early 2000s. So Dr. Vanda Lennon and Angela Vincent from Oxford and Mayo respectively found out that serum of patients with neuromyelitis optica could reproduce the disease. And even before they knew what the antibody was reacting to, they knew that it was a humoral disorder. And later on, they proved that it was aquaporin channels. What exactly does aquaporin do in the CNS? We really don't know, but maybe it has a role in cerebral edema in astrocytes. So in patients who have long-standing aquaporinopathy, the channel seems to disappear from their CNS entirely, yet they still have pretty much normal neurological function. So we don't really understand the role of aquaporin. The other interesting thing is the aquaporin channels are present normally in other tissues like the lungs and the kidneys, but the immune system doesn't attack them there. So that's really interesting. Why? Why does it specifically target them only in the central nervous system? So a lot of questions that we still don't understand about this disease. So how do we diagnose NMO? Again, it's the same principles, a core clinical characteristic with objective proof. In this case, we need an antibody and to exclude mimics. So there are 6 typical syndromes, and we need to know these, okay, of which the top 3 are actually very, very highly predictive of NMO. So you know what those are? Optic neuritis, an LETM, and an area postrema syndrome. So if we have 2 of these simultaneously, they are sufficient to make a diagnosis even in an antibody negative case. But the less typical sites are the acute brainstem syndromes, various types, the diencephalon syndromes, which involve thalamus and hypothalamus, which often presents with narcolepsy, and some brain syndromes as well. Okay, so as I said, 2 of the top 3 classical sites are sufficient to make a diagnosis, even if aquaporin antibody is negative. Okay, so these are some of the atypical NMO lesions. So you can have thalamic lesions, hypothalamic lesions, large subcortical cerebral lesions, which may show faint enhancement, and periventricular lesions. So these are all varieties of NMO lesions. So coming back to our case, the reason we reported this case was she actually presented with a rash, and we thought it was zoster. This happened about a week before her NMO attack. And later on, when we did the multiplex PCR and her antibody test, we found that she had had a flare of Epstein-Barr virus infection. So when we read up about it, we found that there's a lot of evidence linking Epstein-Barr virus not only with NMO, but also with multiple sclerosis. So in NMO, one of the hypotheses is when the virus gets into the cell, the viral coat proteins LMP1 and LMP2A, they actually bypass the safety switch called the CD40 ligand, which is one of the necessary ligands for B cell activation. Okay, so these viral coat proteins mimic the function of an activated CD40 receptor. So now you have a primed B cell that is just waiting for an antigen. It doesn't need the second safety check, so to speak. And this is a very dangerous situation. So this is possibly why our patient and other similar patients who have had Epstein-Barr virus infection are more prone to develop autoimmune disorders. And there is a lot of evidence in the literature saying that the epidemiology of multiple sclerosis seems very much to match the epidemiology of Epstein-Barr virus that occurs late in life. So that's what happens in the West, as opposed to developing countries like ours, where Epstein-Barr virus infection happens very early. That doesn't seem to cause so much harm. But those who acquire it late in life are at increased risk of developing diseases like multiple sclerosis. A brief word about MOG antibodies. So MOG antibodies more often occur in children, and unlike aquaporin, which clusters in Asians and so forth, MOG occurs in all population groups, but it's much less common, around 10% versus 70% of aquaporin positive NMOs. Most of the time, MOG antibody syndromes are monophasic and transient. But there are a subset who develop persistent antibody positivity who require immunosuppression. So the important thing to do in a MOG syndrome is to repeat the antibody after an interval, say about 3 months. And if they're still positive, they need immunosuppression. But if they've turned negative, they can actually be let go. So we'll come to the last part of this talk, which is a couple of spotters, because there are so many inflammatory disorders that there's no way we can cover all of them. But this will be an interesting way to take home some few important points. Okay, so what does this patient have? You can put it in the chat. So this is a classic presentation. 1 week after a recent viral infection, the patient had fever, headache, altered sensorium, was found to have meningeal signs and right hemiparesis. So what do you think this patient has? Okay. Yeah, that's right. Okay, so the diagnosis is ADEM. And why did you say so? So I'll tell you. Excellent. So asymmetric, fluffy lesions. That's right. So they're called flocculent or like cotton wool. Flocculent means like cloud-like. Okay, so I think the pediatric neurologists may see a lot more of this than we do. So generally, these are polysymptomatic diseases. Polysymptomatic meaning they're not just white matter. You see the patient has meningeal signs, headache, fever. So this kind of presentation is more suggestive of an ADEM. Okay, and altered consciousness is one of the key features in these disorders. All right, so this is classic ADEM. Okay, next spotter. So here's another, this is a hypothetical case scenario, not a real patient, but I've just put it down for memory's sake. So a middle-aged man, say 50s, presented with a 3-month syndrome of headaches, glossopharyngeal neuralgia, and a focal CNS syndrome, left-sided limb ataxia and sway. So what do you think this could be? Any thoughts? Tell me the findings at least. What is figure E and the small arrow here pointing at? So the figure here is pointing at diffuse pachymeningeal enhancement. This is the tentorium cerebelli, and it's normally not so thick and visible. Yes, so there is a pachymeningitis, and this is actually a cranial nerve. So it's coming out of the medulla, and it's very lateral. So it's actually a hypertrophied cranial nerve. Now, IgG4 disease is a good thought without this cranial neuropathy. But once you have a cranial neuropathy and focal brainstem and cerebellar involvement, yes, it is sarcoidosis. Okay, so remember that sarcoidosis generally causes multiple cranial neuropathies and pachymeningeal disease and focal brain or brainstem syndromes or spinal cord. Okay, so this is classic neurosarcoidosis. And diagnosis is proved usually by looking for signs of systemic sarcoidosis and demonstrating evidence of neurological involvement on MRI, so forth. Okay, so this is sarcoidosis. Next. Okay, so this is a young woman who presented with a headache for a few months and then has had more than one episode of a stroke. Okay, so what do you think this patient has? So this is a diffusion scan. And if you look at this, you can see that there are lacunar infarcts, which are actually showing some diffusion restriction. So this pattern usually suggests multiple strokes in a young woman with headache. So this would be angiitis, right? Vasculitis. So multiple subcortical and cortical strokes, primary CNS angiitis is a diagnosis here. Okay, number 4, a 38-year-old male with recurrent diplopia, suggesting a brainstem involvement. The patient has recurrent oral ulcers. And that's a big clue. Absolutely. Okay, so everyone got it. Neuro-Behçet's syndrome. So Behçet's syndrome classically produces brainstem signs. So as you can see, a large large T2 hyperintensivity, a lot of edema there, and patchy focal enhancement. Behçet's syndrome is actually a perivasculitis. Most of the inflammation happens around the media, around the veins. So diagnosis is made by proving the consensus criteria for Behçet's syndrome, which involves oral ulcers, genital ulcers, uveitis, and a positive pathology test, and demonstrating neurological involvement in a patient with Behçet's syndrome. Everybody does a HLA-B51 for this. But you need to remember that HLA-B51 is actually not in the diagnostic criteria, and it's, it may be useful, maybe a clue, but it shouldn't be counted as absolute evidence. Okay, so that's our Behçet's syndrome. Let's go to the next case. Sorry that this is a little dark, but look at the contrast between certain regions. Oh, I'm sorry, the answer is up as well. So this is a 50-year-old male with recent onset memory loss and faciobrachial dystonic seizures. So faciobrachial dystonic seizures are very, very classical. It's like almost sudden facial twitch and shoulder jerk or so, just for a second. So this is classically seen in LGI1 antibody encephalitis. That's right. So hippocampal lesions. So this is a limbic encephalitis. You can see the swollen and hyperintense hippocampi in this patient. Okay, what is this? That's right. Hyponatremia is often a clue in LGI1. Okay, so here we have a large lesion, not much mass effect despite its size. And there's a particular finding that is seen here. Do you know what this finding would be? It's called an open ring. That's right. Okay. So this open ring pattern is very classically seen in tumefactive demyelinations. So this is one of the MS variants. So why is it an open ring? Because it's advancing into the white matter. And as it burns its way in, the advancing edge is active while the rest is already damaged. And towards the gray matter, there's not much activity. So that's why it produces this open ring. So this is tumefactive demyelination, diagnosed with open ring sign and a large lesion size, more than 2 centimeters. Okay. This is another classic but very rare syndrome. Anybody who gets this will get a special prize from me. Oh, excellent. Okay, so this is actually called Bailou's concentric sclerosis. So what you're seeing here is parallel lines. I think these guys must have been exam questions or something like that. So you're seeing parallel lines of concentric hyperintensity. This is also a very rare variant of multiple sclerosis. Okay, it is characteristic MRI appearance. Okay, I think the last one, or maybe penultimate one, 50. Oh, wait, I forgot to hide the diagnosis. I'm sorry about that. So 50-year-old male, chronic alcoholic with cognitive decline and gait instability. So classically, what we see here is callosal lesions and also periventricular lesions and diffusion restriction involving the callosum. So that's classically seen in Machia-Favre-Bignami disease. Okay, so let's wind it up here. So just to take home, how do you make a specific diagnosis? Remember the scope approach, that's my term. So syndrome clue, is there a typical syndrome? Can you establish objective proof of involvement on one or more modalities? Can you exclude mix? Okay, and let's just quickly revise. Dissemination in space, periventricular, cortical, juxtacortical, infratentorial, and spinal cord. So you need to have evidence of 2 clinical attacks or 1 clinical attack with MRI evidence to show dissemination in space. And dissemination time either by 2 attacks or MRI showing enhancing and non-enhancing lesions, or a follow-up MRI showing a new lesion 1 month later. Okay, or CSF oligoclonal bands, which proves dissemination in time. So these are the most useful tidbits to take back. So I hope that these things will remain with you. And of course, NMO, one of the 6 syndromes with an antibody positivity, exclusion of alternatives. And the main 3 are optic neuritis, acute myelitis, and area postrema. And 2 of these is sufficient, even if the antibody is negative. And the others, as we said, acute brainstem syndromes, diencephalic, and cerebral lesions. So I'm done here, and I'll stop my sharing. And if there are any questions, please feel free to ask.
So I think there's a question in the chat box.
Okay.
In post-infectious neuroinflammatory disorders, any experience regarding granulomatous herpetic encephalitis, how to manage, and role of long-term acyclovir or neuromodulation?
No, actually, I have no idea about this, but maybe if you've seen one, could you tell us more about it? Granulomatous herpetic encephalitis. I'm not sure how the diagnosis was made, actually.
I'm also not sure. It was a question in the chat box.
Okay.
It was from Dr. Mahalakshmi. She's there, maybe.
Yeah. If you want to tell us more about it, I'll be very happy to discuss it, but I've never seen that, actually.
Okay.
Yeah.
Any more questions, anyone? Okay. Okay, so if there are no questions, thank you so much, sir, for coming.
Yeah, sure. Thank you. My pleasure.
Thank you so much, sir.
All right.
Yeah.